Good morning. I'm Dr. Naval Chandra, Secretary of the.
Yeah,
Uh,
Doctor, please, open your video so that we can see you.
yeah, so I was just waiting for. Okay, now I'm on. Hi. So, firstly, I thank all the participants for logging in for this first of its virtual TS RSSDI, and I thank Dr. Rakesh for putting in all the hard work for getting this conference together. And we'll now move on to the session. It's none other than our dear Rakesh, who will be talking to us for the next 30 minutes. To co-chair this session along with me, we have ma'am, Dr. Neelaveni ma'am. And so without much ado, Dr. Rakesh is going to talk about bridging barriers to therapeutic inertia, focus on Indian patient-centric insulin therapy. So Dr. Rakesh, we all know, we're so well versed with him in Telangana and as well as the national RSSDI, API, very knowledgeable, very well-read person, a very dear friend of mine. So he's on the board of various governing bodies, various fellowships, and over 100 publications. To name a few of the awards, a fellowship of the American College of Endocrinology 2009, fellowship RSSDI 15, ICP 2006, and the HEST senior lectureship oration of the Association of Physicians in 2008. Over 100 odd publications. He's presently the professor and head department of endocrinology at the very famous Usmania Medical College and Hospital here in Hyderabad, and also consultant endocrinologist at Sahai's Endocrine and Diabetes Center, Ameerpet. So over to you, Dr. Rakesh, for your presentation.
Thank you, Dr. Naval, for the very kind words of introduction. I would now go on to my talk. I'm going to discuss about one important aspect which we always have in terms of managing diabetes is getting patients to start using insulin, and that's what I will be discussing today about the barriers to using insulin and how we need to overcome these barriers, and what are the various insulin regimes that we have, and what are the best suited regimes, what makes it very convenient for patients to use insulin. So these issues I'll try to cover in this talk today in the next 20-25 minutes or so. So I'll be speaking on bridging barriers to therapeutic inertia and focusing on the Indian patient-centric insulin therapy. So thank you once again to all of you for being here today. And we all know about the burden of diabetes in India today. We know that India ranks number 2 with in terms of the number of patients with diabetes, and probably we are aiming to be number 1 in terms of the diabetes care that we provide. We have 77 million people with diabetes, and we have a similar number of people with pre-diabetes, and these are the people who are at very high risk of progressing to diabetes, and if things go the way they are going, we may have about 130 odd million people with diabetes in another 20 years. So we don't want that to happen. We want things to improve. We want things to become better, and we want to prevent diabetes and also treat the diabetics who are available with more effectively. And as we've heard in the previous 2 talks, we've heard about corrective, how we could use the RSSDI therapeutic wheel in deciding what form of therapy best suits a patient, and whether you're using the oral anti-diabetic medications or whether you're using insulin. So all these considerations that come into our mind when we are deciding about anti-diabetic therapy has been highlighted in the previous talk. And to base all this, this is all based on good evidence which is available from the UKpedia study, which almost about 20 years back has shown us, more than 20 years back in 1997, we got the first results of the UKpedia study, which showed that with good glycemic control, that is a 1% on an average 1% reduction in V1C, there was a significant reduction in the microvascular complications, almost close to 30% reduction in microvascular complications. Macrovascular disease also coming down by about 16%, and any diabetes related endpoint also coming down by about 12%. And the more important thing that came out on follow-up of these patients was the fact that initial good glycemic control does even better, in terms of saying that even when the ones who were on not so good control in the conventional treatment arm initially, when they also started maintaining good glycemic control, we still saw a difference between those who were initially well controlled versus those who were controlled later on. And this is called as the legacy effect, which we know today, that providing good legacy to the patient by achieving good glycemic control early in the phase of diabetes makes a long-lasting impression in terms of preventing both the microvascular and the macrovascular disease. And this is what was brought out by the follow-up of the UKPDA study, and we all today therefore strive to see that our patients achieve a good glycemic control and get a good legacy in terms of preventing the long-term complications. But as was highlighted by Dr. Bansi also in his presentation earlier, that the major challenge that is there when you're trying to achieve a good glycemic control is the fact that these patients are at a greater risk of hypoglycemia. So we need to balance out between achieving a good glycemic control and at the same time not causing hypoglycemia. So by doing so, I mean, because hypoglycemia, as we know, undoes, whatever gain that you're achieving by a good glycemic control, many a time a lot of damage is done by any even a single episode of hypoglycemia that's happening. And particularly when we have repeated episodes of hypoglycemia, that causes a major problem and therefore increases the cardiovascular risk and cardiovascular morbidity and mortality, and therefore and also the quality of life. And so therefore what we are looking at is achieving this glycemic control without increasing the risk of hypoglycemia. And when we look at the various agents, we just had heard Dr. Sanjay Agarwal speaking about the various considerations that should come to our mind when we are deciding therapy. One of the important things he was highlighting was also the efficacy of any agent or the glycemic efficacy. And if you look at the various agents on this chart, you can see the glycemic efficacy of various agents. And as you can see, metformin is a good agent which brings about reduction in HbA1c to the tune of anything from 1 to 2%. And then similarly, SUs also are very effective in terms of their glycemic efficacy. And if you compare the other agents, they are probably modestly effective in terms of their glycemic efficacy. But in terms of the glycemic efficacy, we see the insulin probably has the best glycemic efficacy in terms of not having a limit to its to the extent to which it can bring down the HbA1c. So insulin clearly stands out as an agent which has a unlimited glycemic efficacy, or rather unrestricted glycemic efficacy, and can be used in many of the patients. In almost every patient, it suits, it fits in very well. But the concern that is there often is the fact of taking an injection, and that's something which and the fact that it interferes with the lifestyle of the person probably increases the risk of hypoglycemia to some extent. So those are the concerns that are there. And if you look at the various considerations as we just spoke, there's often a significant inertia in terms of initiating insulin. Although we all know that insulin has got the best glycemic efficacy, many times we see that there is always a delay in terms of initiation of insulin, and it's happening not only in our country but all over the world. We see this phenomena happening. And if you can look at the RSSDI guideline or the RSSDI ESI combined guideline, this year we had the RSSDI ESI recommendation, that is the Endocrine Society of India and the RSSDI, the Research Society for Study of Diabetes in India, have come together and come out with a guideline which is for the Indian patients with diabetes. And what they have recommended is that they have recommended early use of insulin so as to achieve good glycemic control. And they have highlighted the need for insulin and the fact that insulin should be started at an appropriate time and must not be delayed if the HbA1c remains high in spite of using, say, 2 or 3 OADs. After using optimal doses of 2 or at the most 3 OADs, although we have several different OADs available today, but after using optimal doses of 2 or 3 OADs, insulin therapy should be considered, and that's what is recommended by most of the guidelines. But does it happen so in real life? That's what let us see what happens in real life. There's often a therapeutic inertia, and which is because of several factors. I would discuss some of those factors here. And we know that there are different types of inertia. You know that Newton described this inertia law of today in clinical practice we can say that there is clinical inertia, or where what we are saying is that although we know there's wealth of evidence available saying that this form of therapy is going to be very good, but in spite of that, there is always a delay or sort of delay in terms of initiating that therapy. Either it's in terms of on the part of the physician or on the part of the patient also. And then there is something else called as a therapeutic inertia. Therapeutic inertia means that after initiating insulin, many times we start with a dose of insulin, the particular dose of insulin which we feel is appropriate at a particular point of time, which may be appropriate also, but after a course of time, it may not remain sufficient, and at that point of time, there is need for intensifying the therapy, and there may be a therapeutic inertia in terms of delaying in intensification. So that those are the two inertias that we often see when we are actually looking at the use of insulin. And sometimes there is something called as a clinical myopia, where we are where we are not, we're just looking at the short-term effects rather than we are not looking at the long-term benefits that you're going to provide to the patient by providing better glycemic control, the long-term benefits that are going to happen. Sometimes we fail to look at that, and that is what is called as clinical myopia. So if you look at the various data from different studies and which show when insulin is initiated, and the status of diabetes in different parts of the world, what we find is that in most of the studies, or most of the observational data from different parts of the world have shown that insulin is initiated when the HbA1c level is close to 9% or more than 9%, and some places it is initiated even when it's more than 10%. Although guidelines encourage using earlier insulin therapy, that is, even when you're not able to reach a goal of 7%, even if you're at 7.5 or 8, and have used optimal doses of 2 or more agents, then I think it's time to start using insulin. But that often doesn't happen in clinical practice, as has been seen from different observational studies across the world, which have looked at the status of diabetes care across the world. And it has been shown that people generally start insulin when HbA1cs have gone beyond 9 or 10%. So what could be the factors behind this? There could be inertia on the part of the physician who is starting insulin. It could be because of factors such as patient perceiving that the patient may not accept insulin, and it can be also because of having a concern whether patient will be able to have the self-management skills to start insulin, use insulin, and also having a perception that patient may not understand the problems that he has and not understand the benefits of insulin. So these could be various perceptions that the physician could have, feeling that the patient is not probably best suited for insulin because of these limitations, or it could be because of other factors like misconceptions. There could be misconceptions in the patient himself. I mean, that's very often that we see that patients have misconceptions about insulin therapy, where they feel that it's probably indicating that his disease has become worse or is gone into an end stage, or the fact that some of them even have the concern that insulin may be causing harm, although they don't understand that insulin is the one which is going to protect them from these problems, but often they have this misconception. So it's important that we need to overcome that, or overcome all these misconceptions by educating patients, by education. I think that is how we are going to help in patients overcoming these misconceptions. Apart from that, there are other concerns like distress. Often the patient feels distress that he's probably failing in managing his diabetes. Lack of self-confidence that the patient may have, because he may feel that he's not able to effectively take care of himself. So all those, and also feel that he may not be able to manage the insulin injection and all these factors that may be there. And then there's this view of opposing views. I mean, if he goes to another physician, he may tell him that he can still be managed with oral medications and insulin is not necessary for him. Those are sometimes views that confuse the patient and make him apprehensive about using insulin. The social stigmata that is often there, and finally also the fact that remains that insulin therapy increases the cost of the use of insulin often increases the cost of therapy. So these are all the concerns that a patient may have, And it is important that we understand these concerns. We try to understand what is the major limiting factor for patients accepting insulin, and we overcome this. And most of the time it is with education, because whether it is a misconception, or whether it's the feeling of lack of confidence, or the social stigma, or the fear that he has, it's always going to be by education. The financial aspect of it, we may have to look at using insulin therapy which is best suited for the individual patient. Based on, now we have the option of several different types of insulin available, which could cost anything from just about 150 rupees a vial to something which is about 1500 rupees a vial. So depending on that, we can choose patients as per, choose the insulin as per the patient's pocket, and decide and give them appropriate solutions so that they may be able to achieve good glycemic control. So there are these interactions also. They are the way we convey the news to the patient whether that he needs to start insulin is also another factor which decides. If you are able to convey it in a way in which you don't induce apprehension, you are able to tell him that it is not his failure on his part, but it is the disease progression. If you're able to convey that in the proper way, then I think the rate of acceptance is much better. So the therapeutic settings, apart from that, as we said, that there are other factors that may interfere with insulin therapy, or rather there may be drawbacks for using insulin. One is the limited appointment time that most of us have, and the high patient volume that we have. Sometimes we're not able to provide enough time to the patient to sort of initiate insulin, and so therefore we need to sort of prioritize our work and see that we provide a little more time to those who need to be initiated on insulin, and allay their apprehensions and give them the confidence to start insulin. So these are all the solutions, as I discussed just now, that we need to educate patients, explain to them the benefits of insulin, and tailor the insulin therapy based on the patient's financial needs, also have financial status also, and that would help us so as to see that patients are able to continue with insulin therapy without much interruption in their therapies. So these are all the strategies that can be adopted. As I mentioned, we could provide better messaging to the patient, and in terms of spending a little more time and educating them about the use of insulin, and probably administering the first insulin injection while the patient is in the clinic itself. And so therefore they overcome this fear that they have, and they are able to start using insulin. Now, having overcome these apprehensions and starting insulin, let us look at the other realities that are there, and see whether all patients who are started on insulin, whether they achieve glycemic control or not. If you look at this data, retrospective data of almost 39,000 patients who were treated with basal insulin, what we found is that 50 to 70% of them were failing to achieve glycemic control in the real world scenario. So it is also to understand that there are issues that are there even after starting insulin, that we need to be vigilant about titrating the doses of insulin, and using and also intensifying the insulin therapy so as to achieve the good glycemic control. The easiest form of using insulin is starting a dose of basal insulin, because that is what we find is easy in most of the patients, and it works in most of the patients. But there are certain limitations of using only basal insulin in our country. That is because of the fact that we find that we as Asians and as compared to non-Asians have a little difference in terms of our glycemic profiles, or in terms of our food intake, in terms of various other factors which make us have a more higher risk of postprandial hyperglycemia. So basal insulin, as we all know, is a very good insulin for bringing about a good fasting glucose control, and we continue with the oral agents to maintain to provide the prandial control, and this works in many of the patients. And initially, most of our patients also are able to achieve good glycemic control with the initiation of a single dose of basal insulin, and that happens in practice with most of us. We use basal insulin and are able able to achieve that good glycemic control for a considerable period of time. But there are situations where there are some patients who have a significant problem with postprandial hyperglycemia, and this needs to be addressed because this is not addressed with the oral agents alone in some situations, and where the basal insulin is addressing the fasting hyperglycemia, postprandial glycemic control also has to be addressed. And that is because of the fact that we see that we have a significant carbohydrate intake in our diet. Almost 60 to 70% of our diet is composed of carbohydrates, as has been shown by the starch study, which we looked at the carbohydrate content or the macro nutrient content in the diet in different parts of the country, and we found that across the country the intake of carbohydrates is to the tune of 65%, 66% of carbohydrate intake. And so this is one factor which makes us prone to have postprandial hyperglycemia, and the fact that that almost more than 50% of the day is spent in the postprandial phase, either in the immediate postprandial phase or the post-absorptive stage. The whole thing can be considered as a postprandial phase, and it is during this period that we have significant excursions in the glucose levels, and they contribute to they do lead to a rise in the postprandial control and also in the HbA1c levels. So what we see is that the global guidelines are actually for a diet which is which you can see on the plate on the left side. On the right side, you see a plate which is a typical Indian diet, which has a lot of carbohydrates. As you can see, a huge amount of rice is there in that, and then you have a lot of other carbohydrate intake. As you can see, the chapati here or the puri here has a lot of carbohydrate intake. The rice here has a lot of carbohydrates. So as compared to this diet is more of protein diet, and it is here where you don't have significant postprandial glycemic excursion, and most of the guidelines are addressed towards this type of diet, whereas we are looking at this type of diet in most of our patients, and therefore we need to have our Indian specific guidelines which focus a little more on the postprandial glycemic excursions, and also looking at insulin preparations which have a better efficacy on the postprandial glucose preparation. So towards that end, we have more of premixed insulin used in our countries. We had the premixed regular insulin, which was being used, premixed conventional insulins, which were very popular, and then we had the premixed analogs, which were also very popular in terms of providing better postprandial glucose control, also along with providing improvement in HbA1c levels. But now what we have is a insulin co-formulation called the IDEG-ASP. The IDEG-ASP is a unique co-formulation having the long-acting insulin in the form of insulin degludec and insulin aspart, and which is present in the ratio of 30 to 70. And this co-formulation actually serves very well for an Indian diet, Indian scenario, where you have a high carbohydrate intake and you have high postprandial contribution to the HbA1c, and these patients who are uncontrolled multiple OADs, there's need for a convenient insulin therapy which can provide both the components, that is control of the fasting hyperglycemia with a good basal analog, and also control of the postprandial glucose excursions with a analog insulin which provides much better benefit than the conventional insulin. So this is one formulation which is best suited for the Indian scenario that we are seeing, where we have both the components, that is a significant postprandial glycemic excursion, and there is a need for a good basal insulin also. So if we need to simplify insulin therapy, we could do so with the use of a co-formulation which provides a good control of the postprandial glucose excursions because of the presence of the analog, the aspart, which is there in that aspart, which has a very rapid onset of action, which starts off within 15 minutes, peaks at about 1 hour or so, and the action lasts for just about 2 hours. So there is no shouldering effect which is remaining after the meal, couple of hours after the meal also. So that also is a benefit that is there with the use of aspart as compared to the conventional regular insulin. So this form of formulation provides control of not only the postprandial glucose with the aspart that is present with the long-acting analog in the form of degludec. You have a good fasting glucose control, and therefore you end up with a better HbA1c control. So there is better control, total control of both the fasting and postprandial glucose levels, and a better HbA1c at the end of the. When you're looking at the results of this sort of insulin, use of this insulin. Now, how does this form of insulin balance the glycemic needs? So this is what, let me focus on this in the next few slides. So if you look at the co-formulation, as I mentioned, that it has got the presence of a long-acting analog of insulin in the form of degludec, which has definite advantages over the NPH. As we know, NPH is the one which is present in the premixed conventional insulin, which has problems in terms of causing early morning or nocturnal hypoglycemia, or sometimes causing late afternoon hypoglycemia. So which is prevented by the use of a long-acting analog. These issues may be slightly better addressed in the with the use of a analog, or rather a premixed analog may address some of these issues, but these issues are not adequately addressed. But with the use of a long-acting analog like degludec, you have a good peakless action provided throughout the 24 hours or even beyond the 24 hours, and therefore you have a very low risk of nocturnal hypoglycemia, which is a major concern with the other previous premixed insulins, and you have a better better control of postprandial hyperglycemia with the use of aspart. Now, this IDEC aspart, what does it do? It basically has these degludec dihexamers of degludec, which are present in the co-formulation along with the insulin aspart hexamers. So one of the beauty of these of this molecule, of this insulin preparation, is that this hexamers do not bind to the insulin aspart. So therefore, the aspart is available free in the insulin or in the injection, and it starts working immediately. Whereas with the use of conventional premix, what happens is that the NPH, which is there, the free NPH or the protominated insulin, which is there, binds to some of the aspart also, and prevents the release of the aspart immediately. So that is one problem with the premixed analogs or the premixed insulins, like conventional premixed insulin. But that doesn't happen with the co-formulation, because these two remain separate in the formulation. They do not interact with each other, and so therefore the insulin aspart works rapidly, while the degludec has its protracted action as is expected from this molecule. So it can be used even in patients with hepatic or renal impairment without with some dose modifications. We can use it in patients with hepatic or renal insufficiency, and it is a good option, as has been shown in various studies where it was compared with using IDEG-ASP along with OADs as compared to using glargine with OADs in patients who were naive to insulin, who were not controlled with OADs. When they were randomized to these two groups of these two insulins, it was found in the study that the group that was receiving IDEG-ASP had much better control of their postprandial hyperglycemia and lower HbA1c levels as compared to the group that was receiving only glargine. So this molecule therefore addresses the postprandial hyperglycemia in a better fashion, and patients who are uncontrolled on OADs, insulin initiation with IDEG-ASP offers definite benefits over initiation with insulin glargine, particularly in a setting like ours where postprandial hyperglycemia is also a major issue. And the other beauty of this insulin is that apart from initiating with this insulin, we can also intensify with this insulin. So what happens in the patients who are initiated on insulin is that over a course of time, they have a decline in the insulin secretion, endogenous insulin secretion, because of which postprandial hyperglycemia becomes a factor, and they need insulin intensification. And this often is when you start off with the basal insulin alone, then you need to intensify with the addition of mealtime coverage, which can be done either by changing to premixed insulin or sometimes adding 3 doses of mealtime aspart or any other short-acting analog. And these are sometimes a problem because many patients have the fear with this complex regimes, and also the fear of hypoglycemia is always there. So therefore, because although we know that we need to intensify insulin, we are unable to do it because of these concerns that the patients have in terms of intensification. And therefore, by using this molecule, we can see that intensification also can be done with the same insulin. That is, you start with one dose initially, and then you can go up to 2 doses, and that provides a similar benefit as you would get by using insulin glargine plus 1 dose of aspart or 2 doses of aspart added on to glargine. Would be same effect would be provided by using insulin the co-formulation. So what we are seeing is that providing a simplified approach to patients will help us in motivating them to start off insulin and achieve good glycemic control and maintain good glycemic control over a period of time. So we have an insulin formulation which makes it easy not only to start insulin but also to up-titrate insulin and to intensify insulin and see that the patients may remain at good glycemic control for several years. So even if you look at the latest RSSDI consensus recommendation, which is the RSSDI ESI, this is the earlier consensus recommendation of the previous year, which showed that which has highlighted the role of IDEG as a good instrument to initiate and also intensify therapy with. So in summary, I would conclude by saying that there is evidence and recommendation from guidelines across the world recommending timely insulin initiation for better glycemic control and to provide a better legacy to patients in terms of preventing their long-term complications. The Indian reality is that most patients with the diabetes in India have a very high carbohydrate intake and high postprandial glucose levels, and they need and this leads to uncontrolled hyperglycemia, and they need therapy which is addressing the postprandial glucose levels. And those such patients often require adequate coverage for their postprandial glycemic excursion, and this can be provided premix insulins, and eco formulation like this provides a easy way of providing good glycemic control. So thank you all for the patient hearing.
Thank you. Good morning, all of you, and thank you for the nice presentation, Dr. Rakesh, and nicely discussed on the barriers which we confront, in the sense physician as well as the patient factors, and nicely discussed on the role of premixed insulins or the co-formulations in the context of the India, where our cultural, social and cultural factors are different, keeping in view that how the premixed or the co-formulations are better for our patients so that we can achieve the target HbA1c. And the importance is the best part of the premix, though we have the limitations in using the premixed or the co-formulations, but the best part is you can initiate with in the sense once a day, and then you can intensify. That will be easy for the patient, so that like he can use only a single injection once or twice or thrice depending on the need. That is the best part of it, using the premixed, and we all are using the premixed insulins, though we have some limitations. And thank you for the nice presentation.
A second, I think I can talk.
Yeah, please.
Yeah. Dr. Rakesh has a good presentation, very simplified. So my personal feeling is that there is not much of resistance compared to a decade ago towards the insulin. Forget about the types of insulin, whatever we have been using. But the thing is that at our population, the level of education and the type of population which we are dealing with, I think we are stretching too much on HbA1c levels, which is not that frequently measured, and the patient will be demotivated, because you can just, if you start an insulin, getting a result of fasting or postprandial, maybe a period of 1 week, patient will be motivated because he sees that everything is under control and he gets stimulated. He may try for that. But if you insist upon the only HbA1c at this level, which is not feasible for all the patients, I think slowly it is the physician's role which plays a lot of importance in initiating the insulin for a particular patient and also motivate him. So that's my impression. And I think insulin is slowly picking up, but whatever the thing which you are talking about, the dihexamers. I think that's the latest trend. I think people should be in a position to take over and get the blood sugars controlled.
I think we have Dr. Shyam Sundar who was raising his hand to
Yeah,
ask a question.
yeah.
Dr. Shyam,
Hello,
please go ahead.
hello, Rakesh. I want to know the glycemic index of various carbohydrates. What is the impact on the postprandial surge?
Yeah, actually, what we have seen is that as we have seen, one aspect is the carbohydrate content in the diet. Other is the type of carbohydrate that is taken. So if you take a carbohydrate with a high glycemic index, that requires more, more insulin, more postprandial, more insulin to cover that, or more insulin to bring down to avoid the glycemic excursion that happens. So that's how the food with higher glycemic index will definitely have a greater need for, greater requirement of insulin. So of insulin, the prandial insulins. And so I think, although discussing about the glycemic index, the various types of foods with different glycemic index, in short, we can say that, complex carbohydrates like the one present in unpolished rice and say the coarse grains or the unpolished grains they have a lower glycemic index as compared to the polished rice and all that. We have way higher glycemic index. And then bread is considered as the sort of standard against which the glycemic index is measured. So this is in short about the glycemic index. And things like when you take add vegetables and fiber in the diet, that reduces the glycemic index of the overall meal that you're looking at. Yeah.
Rakesh, there are two questions on the Q&A. If you can have a look, they're addressed by the same person. The first one is on what do you mean by conventional treatment? And the second one is, with this premix injection, how will you address the post-lunch sugar?
Yeah. So basically what I was mentioning about conventional, I think I used it twice in my presentation. One is conventional, and is saying UKpedia study what was intensive and conventional. The conventional therapy was what was the norm at that time they were following. And they were keeping the blood sugars in the range of 200 fasting and around 250 up to 250 was considered not requiring therapy and all that. Only lifestyle measures were used. So that was the conventional therapy in the UKPDs. But coming to insulin, I used the term conventional 2 or 3 times when I spoke about the regular insulins. So that is the human insulin. Now we don't have the animal insulins. About a decade back or 10, 15 years back, when we used to use animal insulins, and we used to say that we used to call the human insulin as the newer insulin. Now we don't have the animal insulin available, and the human insulin is the conventional insulin, and whatever analogs we have is the newer insulin. The analogs are the newer insulins. So this is what we mean by conventional insulin. If we are talking about conventional insulin, we are when we are talking about either the regular insulin or the NPH insulin or the premixed insulin that we have. So those are the conventional insulins. So that was what I was addressing. And how does this address the premix, the post-lunch sugar? That's what. So what we are trying to say is that if you're using this insulin once a day, then you identify which meal of the day is the largest meal, where there is maximum glycemic excursion, and use it along with that meal. While you use OADs, continue to use OADs along with other meals. So if in a type 1 diabetic where there is a need for providing a full basal bolus coverage, there you don't use this once a day. You have to use it at least 2 times a day, and along with a rapid acting analog to be used in the afternoon or something like that. That is how you use it in type 1 diabetes, or a type 2 also, where you require a full basal bolus coverage. But this is what we are speaking of is in type 2 diabetics who require some coverage. So there you may identify if one of the meals has a very significant glycemic excursion, you can identify that and use it at that time, so that it provides the basal insulin and also provides the glycemic covers for the glycemic excursion during that. So that is how you can cover the meal with the greatest glycemic excursion. Now another question is about financial constraint situation. What insulin co-formulation you suggest? So as I mentioned, that the major, we have insulin ranging from 150 rupees to say 1500 rupees. So this is coming in the higher range. So if you are looking at people who cannot afford this form of insulin, then premixed insulin is is better, or you can use, or you can mix it as per the requirement. That is called a split mix. We used to call it a split mix, where you give basal insulin separately and give the prandial insulin. Even you can use regular insulin also 3 times before each meal, and that is what you can achieve good glycemic control with that. Or if you feel that the patient can do well with the premixed insulin, there are some limitations of premixed insulins, but you can also achieve, use them, and many of our patients are achieving good glycemic control even with premixed insulins.
Okay, there's another question which says, in newly detected patients with raised HbA1c with normal FBS levels, is it necessary to start anti-diabetics?
Yeah, raised
by Dr. Y. Reddy.
Yeah, in those, I think the most important thing is to address the lifestyle issues, see that they change their diet, start exercising regularly, and that itself is enough in most of the patients. So, I think that's the approach that we should follow. And particularly changes in the meal, avoiding high glycemic index food, that will take care of the postprandial excursion also. The fasting is normal, you said.
So I think we've come to the end of this.
Dr. Sahay,
yes.
Do you have any head-to-head studies with Idagas with Glargine U300, sir?
I think we still are awaiting data on that. We should be looking for such studies. I think we don't have available data on that right now.
Thank you. Thank you, sir.
So if there are no further questions, I, on behalf of my panelists, Dr. Neelaveni ma'am and Dr. Nagender sir, thank the TS RSSDI for having us chair this session. Thanks, Dr. Rakesh, for a very elusive presentation. And back to you, I guess.
Thank you.
Thank you. Thank you, Dr. Naval, Dr. Nagender, and Dr. Neelaveni for being here.